Thank you very much, Lynn. And I will tell you that two things. The introduction that Lynn gave just is to tell you that I'm old. I've been doing this for 22 years. And I can tell you, just listening to briefly your stories, it was very shocking. And I'll tell you, it is patients like you who help us as providers sort of do this on an everyday basis because we have to do better. I had done something similar with regards to non-small cell lung cancer a couple of months ago. Maybe now it's about 3-4 months ago that Lynn had asked me to do. And so I'm going to do a presentation today on small cell lung cancer. I am going to sort of present slides, but my hope is that that just sort of sets the table, so to say. And then I'm really open to sort of discussing with you and possibly answering some of your questions. And so if anybody attended that presentation, there might be a little bit of a repetition, and hopefully you will still find it worthwhile. I always start off with what is cancer. And again, you folks appear to know this disease in some ways better than some providers. But at the end of the day, cancer is because there are certain genes that have been damaged within our cells. So we all are made up of something called as cells. Usually these are round in structure and they're really tiny. So in the tip of my little finger, there could be up to 1 million cells. And each of our cells have two sets of genes, one from our father, one from our mother, and it's the genes that tell our cells what they're supposed to do. And in every cell of our body, we have the same set of genes. And depending upon where the cell is. So in the heart cells, certain genes are active. They tell the cells what they're supposed to do. And that's what makes a heart cell a heart cell. In the lung cells, the same genes are present as in the heart cells, but a different set of genes are active. They tell the lung cells what they're supposed to do. And that's what makes lung cells function as lung cells. Now, during our lifetime, we can acquire damage to these genes. The damage could occur through many different things in the environment, things in the diet, things in the water. And something that can damage the genes, particularly in our lung cells, is smoking. Now, I just want to say I've just put smoke there. I don't want to sort of continue the long-term sort of this, lung cancer patient, that must be smoker. There are a lot of patients who are never smokers who get lung cancer. And so I've only put that there as a way that there are environmental agents. We think about gene mutations as something that we inherit, but we could have inherited a normal set of genes, completely normal set of genes, but we could acquire damage to the genes. And one of the factors that can damage is smoking. So the blue portions in the set of genes and some of the deviations here are supposed to represent the gene damage that can be acquired. Now, a couple of things about gene damage. Let's say you had 3 different individuals growing up in the same area, same background, smoking, let's say the same cigarette, same length of time. One person may not pick up any gene damage. Another person may pick up this kind of a gene damage, and a third person could pick up completely different type of a gene damage. Why different individuals, despite getting exposed to the same environmental agent, either don't pick up gene damage or pick up different types of gene damages? Again, something we don't understand. And when I say pick up gene damage, it's something that happens over a period of years. It's not something that happens one fine day. And so there are patients that I see who tell me, why you bring up my smoking? I stopped it 10 years ago, 15 years ago, 20 years ago. But once a gene damage process is set in motion, it is self-sustaining. And even if you withdraw the factor that started it in the first place, the gene damage process can continue. Now, just because there's gene damage doesn't automatically mean there's a consequence. There is enough redundancy. There are normal genes that can compensate and the cells can continue to function normally. But if the damage occurs at certain specific points along the genes, the damaged genes start giving wrong commands to the cells, and that flips a normal cell into a cancer cell. And there are 2 main features that distinguish a cancer cell from a normal cell. A cancer cell keeps on multiplying. 1 forms 2, 2 forms 4, 4 forms 8. Normal cells can also multiply, but they only multiply up to a certain number of times, and then they stop multiplying because the normal genes tell them to stop multiplying. In the cancer cells, they keep on multiplying without any rhyme or reason, and they don't stop multiplying because the damaged genes, the cancer genes, tell the cancer cells to keep on multiplying. Eventually, some of the cancer cells derive the ability to detach from the main mass, get into the blood vessels, and through the blood vessels, they can travel to other parts of the body and start growing there. Normal cells do not have the capacity to detach from where they're located and go to other parts of the body. Cancer cells derive that ability because the damaged genes tell them to do so. So any cancer is our own tissue that is growing when it is not supposed to, and a portion of the cancer detaches from the main mass, gets into the blood vessels, travels to other parts of the body, and starts growing there. If this process starts in the lung, it's lung cancer. Starts in the kidney, it's kidney cancer. If it starts in the colon, it's colon cancer. But even though these are, each of these are cancers, the way each of these cancers grow, the areas that they spread to, and more importantly, the treatments that they respond to are very different from each other. So the way we treat lung cancer is not the way we treat colon cancer, is not the way we treat kidney cancer. And, I'm sure this group knows that extremely well, but this is sort of my discussion I have with my patients during the first visit, because generally during a new patient by the time they see me, has talked to some family and friends, and they've been informed, they can do this in your cancer. And what's applicable for kidney cancer and colon cancer may not be applicable for lung cancer. And I'm sure this group knows what's applicable for non-small cell lung cancer may not be applicable for small cell lung cancer, and vice versa. So it's very important to note that even though these are all cancers, they're almost like different diseases, and you don't treat them exactly the same way. And then finally, if you have lung cancer and that spreads to other parts of the body, the bone, the liver, so when it comes to lung cancer, both non-small cell and small cell, the common area of metastases are the lungs itself. So you can have lung cancer start in one portion of the lung and spread to other parts of the lungs. It can spread to something called as the pleura, which is the lining around the lungs. It's a thin membrane, works like a lubricant, so thin that on a normal CT, you can't see it. But lung cancer can spread to the pleura and cause sort of fluid there and squish the lung, and that can cause shortness of breath. It can spread to the liver. It can spread to something called as the adrenal glands. These are organs that sit on the top of the kidneys. They are not connected to the kidneys. They just sit on the top of the kidneys. They can spread to the bone, and they can spread to the brain. Now, a couple of things. Not in every patient, lung cancer spreads to all these organs, and it can spread to organs other than the ones I mentioned. Why in some patients it goes to the liver but never goes to the brain, or goes to the liver and brain and never goes to the bones, we don't understand. And then there are some patients where it goes to an unusual organ, unusual in terms of lung cancer spread, to the kidneys or the pancreas or the gut. These are not common sites of metastases, but that may occur. So why in some patients that occurs both in non-small cell and small cell lung cancer? And so the important thing to remember is that one of the first things we do when we diagnose lung cancer, whether it is small cell or non-small cell lung cancer, is we want to know what is the extent of the cancer. And generally, and there are always situations where this could be different, generally, what we do is we do what is called as staging studies. So it commonly involves a CAT scan of the chest, sometimes CAT scan of the chest, abdomen, pelvis. In small cell lung cancer, once you've diagnosed small cell lung cancer, it doesn't matter what is the extent of the cancer. We always do a brain scan, and preferably it is a brain MRI. I know some patients have difficulty in tolerating brain MRI, in which case we do a CAT scan. And that's just because small cell lung cancer, among all cancers, is probably the greatest propensity to spread to the brain. That doesn't mean it occurs in every patient, but brain scanning is very critical part. And then, of course, a PET scan. But one thing I want to explain is that if you have lung cancer that has spread to the liver, and again, I'm sure this group knows, just going through some of the things I talk to my new patients, If the lung cancer spreads to the liver, that doesn't mean that patient has liver cancer. It is still lung cancer that has spread to the liver. And whatever treatment we are going to give for the lung cancer in the lung should, if it is going to work, it should work against the lung cancer that has spread to the liver. Because there are patients who ask me, okay, you're giving treatment for lung cancer, but what about that cancer that has spread to the liver? Well, that treatment that we are giving, if it is going to work, it is going to work at both places. And it's important to remember that if somebody has liver cancer that has gone to the lung, that patient doesn't have lung cancer. That patient has liver cancer that has gone to the lung and will get liver cancer treatment. So it is very important to understand that when it comes to cancer management, you need to know what type of cancer it is and where it started. And I think this group, more than anybody, knows that even when it comes to lung cancer, there's nothing really called lung cancer. It is non-small cell and small cell lung cancer. And then within non-small cell lung cancer, there are subtypes like adenocarcinoma, squamous cell carcinoma. And the treatment is quite different between these different cancers. Now, you might hear one of the first things we do is stage the patient's cancer, because treatment to a large degree is based on what is the stage of the cancer. And many of you know, in most cancers, there is stage 1, stage 2, stage 3, and stage 4. And that is true for small cell lung cancer. And before I go to the stage, in general, despite all the advances that have occurred both in non-small cell and small cell lung cancer, the two major prognostic features in any patient is what is the stage of the cancer and what is the overall performance status. I'm going to talk about the stage, but I just want to briefly talk about the performance status. Performance status in general is an assessment, and it's a bit subjective. It's the assessment by the treating physician, treating provider, about what is the activity level of that particular patient. And what we tend to do is compare that patient's activity currently to what it was at baseline before they became ill. And depending upon how much the activity has declined or stayed the same, we decide what the performance status is. Of course, when the activity level is lower, the performance status is lower. And the reason performance status is very important in deciding treatment and is impactful in terms of prognosis is because performance status is a good predictor of how well the patient is going to tolerate treatment. The chances of side effects with any of the drugs that we are using, not just chemotherapy, but yes, it is particularly true for chemotherapy. The body's ability to tolerate these drugs is influenced by the body's performance status. So lower the performance status, greater is the likelihood of side effects. Now, as you can realize, performance status could be lower because of the lung cancer itself. But many times lung cancer patients, whether it is non-small cell or small cell, have other conditions, heart conditions. Some patients have COPD, and that can lower performance status. There could be a difference in the way we determine what is the performance status based on what we think is the most likely cause of the lower performance status. In that, if the lower performance status seems to be primarily related to the cancer, that is, the patient was quite well, but got diagnosed with lung cancer, and now the performance status has reduced. In general, and there are always exceptions, in general, treatment is something we would still pursue because that patient's performance status is lower because of the fact that the cancer has impacted. And if we can shrink the cancer, we expect the patient's performance status will improve. On the other hand, if the patient's performance status is lower because they have kidney disease or heart disease or lung disease, and sometimes in lung cancer patients, sometimes these organs are not functioning well, then in that situation, that patient may actually have a bit of a harder time tolerating these treatments because many of these organs help the body tolerate these drugs. And so if these organs are not functioning well, the side effects might be greater, and we may not be able to deliver treatment in an effective dose, effective schedule to provide benefits. And then in some patients, of course, it's a combination. It's the cancer and the other conditions. So assessing performance status, I know I spent a little bit more time than I wanted to, is very critical. And that's something that sometimes we don't, as doctors, discuss, because it is never, a positive thing to discuss a patient that, oh, your activity level is not good. They're not doing that on purpose. And we say, we are a bit hesitant in the dose we want to give or the drugs we want to give, because we are worried that we may actually cause more harm than good. And the other factor that is relevant, as I mentioned, is stage. And when it comes to small cell lung cancer, yes, we have stage 1, 2, 3, 4. But to a large degree, from a practical point of view, there are essentially two stages: limited stage and extensive stage. And the reason in small cell lung cancer there are, is broadly speaking, two stages, is because in general, based on the study of small cell lung cancer, we assume, however, whatever the sites of disease are, we assume that the cancer has spread. Because small cell lung cancer, more than non-small cell lung cancer and more than many other cancers, has a significant propensity to spread to other parts of the body. So even if on all the scans you detect lung cancer that is limited to the lung, we assume the cancer has spread to other parts of the body. It's just that wherever else it has spread to, it is not yet detectable on the scans. And the reason I'm saying that is that even when the cancer appears to be limited or restricted to the lungs and maybe the lymph nodes, it is not sufficient just to deal with the cancer that we see on the scans. But we need to ensure that we are also addressing the cancer that we know has spread to other parts of the body, but not big enough to be seen. And so the difference between limited stage and extensive stage is that in limited stage, the lung cancer, on all the scans we do, from brain to the PET scan to the CAT scan of the chest, the only site of disease you can see is in the lungs, either one of the lungs, and maybe it has spread to the lymph nodes, but we don't see it anywhere else. And in the extensive stage, we see it in other places. But even though in limited stage we don't see it anywhere else, we use treatment that goes everywhere, which in small cell lung cancer is chemotherapy. Of course, there are other therapies now. Is chemotherapy, because chemotherapy is given intravenously. It not only goes to the lungs, it goes to all parts of the body. And so even when the cancer is limited to the lungs or lymph nodes, we always use chemotherapy. The only difference between limited stage and extensive stage is that when the cancer on the scans is limited to the lungs and we don't see it anywhere else, in addition to chemotherapy, we would do either surgery if it appears to be limited to the lung itself without any evidence of lymph nodes. But if it has spread to the lymph nodes, we would do radiation. And generally, we would do radiation with chemotherapy, because chemotherapy makes the radiation stronger against the cancer than what it would be by itself. When it is extensive stage, when we can already see it at other places, we only do chemotherapy because there's no added advantage in general to do additional treatment to one area if you can't do it to all areas. And you can't radiate the entire body because that would not be tolerated by the patient. And so it is when we can see cancer at other places, the treatment is to give treatment that, like chemotherapy, that goes everywhere. And the outcome of the patient is not based on the largest area, but on the entire cancer. And so that's why in extensive stage, we'll end up doing a treatment that goes everywhere only. And we generally, though there are exceptions, and I'm going to present a case at the end that is going to tell us that exception, we generally don't use local treatment. So for years, the treatment that has been used in small cell lung cancer has been chemotherapy. And actually, chemotherapy works quite well, at least in the beginning. In fact, the response rates in small cell lung cancer are far better with chemotherapy than they are with non-small cell lung cancer. And I can tell you that initially there is significant improvement. There's significant shrinkage of the tumor, and the patient really, most patients, nothing works 100%, but a very high proportion of patients feel much better after starting chemotherapy. One other thing I did not mention and I did not put up a slide on is that in general, small cell lung cancer is a faster growing cancer than non-small cell lung cancer. And it is actually because it is faster growing that it responds to chemotherapy, at least initially, quite well. And in fact, because it responds to chemotherapy quite well, there were a lot of efforts over the last 30 years to see if we could do stem cell transplant, that is, give so very high doses of chemotherapy to try and kill the cancer. But they are so high that the bone marrow also gets sort of eliminated. And so what we do is cancers such as leukemia, lymphoma, we store the patient's bone marrow, collect the bone marrow, store it, freeze it, and then give high dose chemotherapy to eliminate leukemia, lymphoma, and then give back the bone marrow so that the patient's bone marrow can be reconstituted. That effort was tried in small cell lung cancer because initially it responds so well to chemotherapy. People thought, okay, if we just give a very high dose, we should be able to get rid of the small cell lung cancer. And it was not successful because what happens is that small cell lung cancer does respond, but beyond a certain dose, you don't get more response. So there is a sort of a threshold beyond which you don't get any greater benefit with chemotherapy. And that's why those endeavors of adding more chemotherapy, giving higher doses, doing stem cell transplant, that's what the focus was over the last 30 years. And unfortunately, though, well-intentioned, those efforts were not successful. And the first success really in the last 30 years has been the addition of immunotherapy. And there are 2 trials and 2 drugs that are now FDA approved based on these 2 trials. The first trial was with atezolizumab, and the second trial was with durvalumab. The commercial names are Tecentriq and Imfinzi. And so what was done, just briefly, and again, I'm sure this group knows, what these drugs do is these are immunotherapy drugs, but also they're called immune checkpoint inhibitors. And so what does that really mean? Our immune system, and this T cell is sort of here in this figure representative of our immune system. Our immune system is so engineered that it is supposed to fight infections and cancers when they emerge in our body. And it is also so engineered that it is supposed to protect normal tissue. It is not supposed to attack normal tissue. However, when cancer develops, many cancers, almost all cancers, when they do develop in a patient, partly they are able to develop because the cancer, here represented by the tumor cell, fools the patient's immune system, the T cell, into thinking it is normal tissue. So the immune system, the T cell, is able to see the cancer, but is not recognizing the cancer. In fact, it is wrongly recognizing it as normal tissue. And our immune system is not going to launch an attack against normal tissue. And this happens because the cancer has on it something called as PD-L1. And this PD-L1 kind of hooks on to PD-1 on the immune cell. And when PD-L1 on the cancer cell hooks on to PD-1 on the immune cell says, oh, this is a normal tissue, I should just go to sleep. And that's how the cancers kind of evade the immune attack from the immune system. So what Imfinzi and Tecentriq, and you may have heard Keytruda or Opdivo, what they do is they block this interaction between the PD-L1 on the cancer cell with the PD-1 on the immune cell. And once you block that interaction, once you prevent the PD-L1 on the cancer binding to the PD-1 on the immune cell suddenly wakes up and sees, oh, there's a cancer there, and launches an immune attack and kills the cancer cell. So the drugs themselves are not killing the cancer, but they are helping the immune cells recognize the cancer as cancer. And then once it does so, the immune cell attacks the cancer cell. So what was done is that this drug, atezolizumab or Tecentriq, was combined to standard chemotherapy, which essentially is something called as cis or carboplatin. Cisplatin and carboplatin are kind of cousin drugs, combined with a drug called etoposide, or VP16 is another name. And this has been the standard chemotherapy for some time for the use of small cell lung cancer. And what was done in this trial is half of the patients. Now, these were all patients whose cancer had spread to other parts of the body, had extensive stage small cell lung cancer. And they got, half of the patients got chemotherapy and this immunotherapy Tecentriq, and half of the patients got chemotherapy and placebo. And what this study showed was that there was an improvement in survival with the addition of immunotherapy. Now, I have to say, if you can look at the curves, for a large part of the curves, they overlap with each other. They're very close to each other. It is only after a certain period of time that they start separating. And based on these curves, what the impression is that it's a minority of patients that are deriving benefit with the addition of the immunotherapy Tecentriq to chemotherapy. But when they derive benefit, it appears to be a sustained benefit. So there is a good proportion, very candidly, that addition of immunotherapy to chemotherapy doesn't appear to provide benefit, but it's a minority of patients where when you add immunotherapy, not only it provides benefit, but the promise of immunotherapy, not only in small cell lung cancer, non-small cell lung cancer, but other cancers, is that when it works, when you activate the immune system can keep the cancer in check and do so for a very long period of time. And that is what results in this difference in 12 months, 18 months. So a 13% difference. Now, 13%, the difference doesn't seem a lot, and it is not a lot. But in the context of the fact that for 30 years, there has not been advance, now to have at least some patients derive that sustained benefit is quite gratifying. Again, just the beginning, we need to be much further along in this disease than where we are. This is a longer follow-up of the other trial. This is what is called as the Caspian trial. In this study, they used the drug Imfinzi, but the results are identical. But this was an updated data from the Caspian trial. And you can see approximately 20% of the patients at 3 years are alive, and a good proportion of these patients don't have active disease, and some of them may not be receiving treatment. So to have a proportion of patients with the addition of these drugs derive that sustained benefit is quite sort of impressive, if I can say that. And a lot of efforts with immunotherapy are being made to try and see if that proportion of 20% can be made 40%, 50%. And that's the growth. So we are not necessarily looking at medians. A lot of people, when physicians discuss the results of these trials, they say, oh, there's a 2-month improvement in survival compared from chemotherapy to the addition of immunotherapy to chemotherapy. I don't know that that's the correct way of stating the benefits of these drugs. Frankly, the benefits are limited to a minority of patients, but when they work in those patients, the benefit is sustained. And again, I am going to discuss a patient of mine to sort of make this point. So clearly, one of the goals is to identify, is there a way to identify who are these patients who are deriving that sustained benefit? And I heard just now that you're going to have investigator from MD Anderson do a presentation. And that group has done quite a lot of work in looking at these cancers genomically and understanding the gene alterations in these cancers. And broadly based on that genomic analysis, these cancers have been divided into 4 types, A, N, P, and I type. And I'm sure that investigator will go into much more details about this because it seems that he studies biomarkers. And it appears that the group that has the greatest chance of benefit with the addition of immunotherapy to chemotherapy is the I group compared to the other groups. Now, this is something still within kind of the laboratory setting. We don't have a good test right now where we can distinguish these different subtypes. in patients' cancers and kind of assign, okay, the patient A's cancer is type A or patient's B cancer is type I. But eventually, over the coming years, and I don't think many years away, but in the next, say, even 1 to 3 years, there's a good chance that we will be utilizing these kind of systems or biomarkers to understand, okay, this patient is likely to derive benefit from the currently available immune checkpoint inhibitors, immunotherapy, but this patient probably is not. So let's test newer immunotherapies in that patient, which may be more beneficial in those patients. And I really think that that's where we are headed. So, right, something similar to non-small cell lung cancer, where we no longer consider just non-small cell lung cancer. There's EGFR lung cancer and ALK lung cancer and so on and so forth. Until now, it's just small cell lung cancer, and it is quite likely that these tumors will be divided into subtypes, and we will have more precise therapy for the particular type of small cell lung cancer a patient has. And an example of that is something called as PARP inhibitors. PARP inhibitors are right now approved for breast cancer and ovarian cancer, and they may have benefits in small cell lung cancer. There is data to suggest that a marker in small cell lung cancer called SLFN11, it is also called SLFN11, but SLFN11, if that marker is present in the patient's small cell lung cancer, this is something we can test on the biopsy, then there is a good chance, at least based on laboratory data, that these PARP inhibitors, and there are few PARP inhibitors that are approved for breast cancer and ovarian cancer, and those PARP inhibitors may be beneficial in small cell lung cancer when given in combination with chemotherapy. And in fact, study was recently completed wherein patients who had extensive stage small cell lung cancer received chemotherapy and immunotherapy for 4 cycles. And after 4 cycles, the standard of care is to just continue the immunotherapy for as long as the patient is deriving benefit and as long as the patient is tolerating treatment. But what this study did was, in patients who had completed the chemotherapy and immunotherapy, they tested the tumor of the patient for this SLFN11. And if the SLFN11 was detected in the patient's cancer from the biopsy, then half of the patients continued on the immunotherapy, which would be the standard of care, and half of the patients got this PARP inhibitor called talazoparib in addition to the immunotherapy. Now, this is a pill that you take in addition, and we will see if in this particular subset, so this is not all small cell lung cancer patients, and SLFN11 is detected in about 40 to 50% of small cell lung cancer patients. And so we will see if the addition of the PARP inhibitor in this subset of small cell lung cancer patients adds to immunotherapy. So what I would like to say is, we know that addition of immunotherapy to chemotherapy improves outcomes. But we also know it appears that it is mainly limited to a minority of patients that derive that sustained benefit. So how do we move the field forward? One is to try and identify the patients who are most likely to derive benefit from immunotherapy by doing these kind of genomic tests and understanding what subtype of small cell lung cancer a particular patient has, and then use immunotherapy primarily in those patients that are likely to benefit based on the subtype. And then for others, what we can do is identify other biomarkers that will allow us to combine other drugs with immunotherapy to improve the benefits of immunotherapy in those patients. And the hope is, not only do we improve effects of immunotherapy by adding newer drugs, but also use current drugs and use biomarkers to either add drugs or look at alternative strategies beyond immunotherapy for certain subset of small cell lung cancer patients. Now, in some patients, of course, this initial therapy works, but after a period of time, the patient's cancer progresses. And there are several other chemotherapies that can be utilized. The 2 commonest are something called as lurbinectedin and something called as topotecan. Lurbinectedin is relatively new, approved about 2 years ago, and has become more of a commonly used drug, more commonly than topotecan, primarily because it's more convenient. It's an infusion on one day every 3 weeks. Topotecan requires 4 to 5 days of infusions every 3 weeks. And so mainly because of convenience, lurbinectedin is preferred as the first drug used after initial chemotherapy and immunotherapy. But in many patients, we do land up using topotecan or many of the other chemotherapy drugs that can be utilized in this patient. This is about lurbinectedin, the drug I told you. So there are many, many drugs that are currently in development to treat small cell lung cancer. And I'm just giving you a few examples about what drugs are being evaluated. And this evaluation is primarily occurring in extensive stage small cell lung cancer and primarily occurring after receiving chemotherapy and immunotherapy. And one strategy is a different type of immunotherapy these are called BiTE drugs, and they are sort of bispecific antibodies. And what that really means is that there is a substance present, we call it an antigen, a substance present called DLL3 in 80% of small cell lung cancer patients' cancer. It's not 100%, but in 80% of small cell lung cancer patients' cancer. And so the drug consists of two components. One component binds to the DLL3 that is present on small cell lung cancer. And the other component, the blue component represented by blue component here, binds to something called as CD3. And CD3 is present on immune cells. And so what this drug is doing is basically bringing the immune cell and locking it through the drug to the cancer cell. And this lock activates the immune cells and makes them fire kind of missiles to the cancer, and the cancer basically explodes. So the drug is basically bringing the immune cell close to the cancer cell and then locking it. And once it locks, it activates the immune cell. It releases certain substances, I call them missiles, and that basically leads to the cancer exploding. This drug is in clinical trials and has shown benefit. It has been primarily evaluated in patients who have gone through chemotherapy and maybe another 1 or 2 other chemotherapies. And it has shown promising results. Again, works in some patients, but once it works, it can cause sustained benefit. One of the problems is that this drug can really activate the immune cells, and the immune cells release a lot of substances into the system, not just towards the cancer. And that can cause fever and chills and shortness of breath for a short period of time. And therefore, right now, at least the first infusion is done inpatient. But those side effects are generally quite manageable. And then after the initial infusion, the subsequent infusions can be done as an outpatient. But this is another way of activating the patient's immune system to fight cancer. And this is sort of the data on this drug. Now, there are a couple of other sort of drugs that are being looked at, and I'll come then later on to the limited stage disease. There is something called as antibody drug conjugates. Basically, this is targeted chemotherapy. These are antibodies that bind to specific substances that are exclusively present on the cancer and not present on normal tissue. And these antibodies have these linkers represented by these tiny yellow lines to which is bound chemotherapy. So the linker is that line, and the chemotherapy is the round structure next to that line. And this linker binds the chemotherapy to the antibody. Once it is bound, the chemotherapy cannot work. But this is a pretty toxic chemotherapy, pretty potent chemotherapy. And the antibody only binds to a substance that is present exclusively on the cancer and not present on normal tissue. And so when you give this drug intravenously, the drug circulates, and while it is circulating in the system, the chemo can't work. But once it reaches the cancer and the antibody binds to that particular substance, and that is the only substance the antibody can bind to, it gets into the cancer, and then the linker is broken and the chemotherapy is released into the cancer, and it is so toxic that the cancer is killed. And so this is chemotherapy, but it is targeted delivery of chemotherapy. And there are drugs like this being evaluated in small cell lung cancer. And finally, there are efforts of doing what is called as cell therapy, where you kind of remove a small portion of the cancer. And this is being done mainly in non-small cell lung cancer, but I suspect eventually it will be done in small cell lung cancer, where you remove a portion of the cancer, a small portion of the cancer, to extract immune cells that have already reached the cancer, but need to be juiced up a bit to kill the cancer. And those immune cells from the portion of the cancer that is removed are extracted. They are sort of grown in the lab. They're given vitamins and different drugs to boost them up. Not vitamins, I'm just saying things to boost up the immune cells. And then those immune cells are infused back, and these juiced up immune cells can then kill the cancer. And that has shown some promising results in non-small cell lung cancer, but the expectation is similar efforts are going to go on in small cell lung cancer. We talked about extensive stage small cell lung cancer. What about limited stage small cell lung cancer? So the standard treatment, now this is cancer that is limited to the lungs. We don't see any evidence of cancer anywhere else. But mind you, as I mentioned, there is cancer at other places. It's just not big enough to be seen. So that cancer generally is treated, limited stage small cell lung cancer is treated with chemotherapy and radiation generally. And there are several trials going on that are looking at adding the checkpoint inhibitors that have shown benefit in extensive stage disease in this stage of small cell lung cancer. But we are awaiting the results of these trials. They have completed enrollment, and one expects that we will have results next year. And it is quite likely that not only do we use these checkpoint inhibitors like Tecentriq in extensive stage small cell lung cancer, but also limited stage small cell lung cancer. I wanted to sort of finish up by talking about screening. Whenever we talk about lung cancer, I feel it is important that we talk about screening. Lung cancer screening does improve, reduces lung cancer related mortality. And if you know anybody who is above the age of 50, has a 20-pack years smoking history, or may qualify on other basis. So above the age of 50, 20-pack years smoking history, they should undergo a CAT scan screening to detect lung cancer as early as possible, and the cure rates are definitely improved. Right now, lung cancer screening is based on CT scan. I can tell you there are blood tests. This is still in development, not yet FDA approved, but there are blood tests that are being developed to detect cancers, not just lung cancer, but several cancers very early. And the hope is that this could be another tool in detecting cancer at an early stage and curing more patients. Briefly, clinical trials are very, very important for the development. There are a lot of patients who are concerned about enrolling in clinical trials because they feel they're being made a guinea pig. But actually, a few things to remember. It may be the only way to get some of the newest and most promising treatments. And what is important to recognize is that in some way you're getting opinions from many experts, because these clinical trials have to be reviewed by a lot of authorities. And only after such a review are these clinical trials opened for enrollment. And so in a sense, all the experts who have reviewed these clinical trials believe that if a patient meets the criteria for the trial, then enrolling in the trial is definitely an option, not the only option, but an option And so in a way, you're getting an opinion of multiple experts. In generally, in trials conducted in the United States, one doesn't receive placebo. Usually you receive the actual drug. Though there are placebo-controlled trials, they usually are placebo-controlled trials where they're trying to see if adding something to standard of care treatment. So you're going to get standard of care treatment. You may not get the active drug, but that's the only way that we can know whether adding the experimental drug makes a difference. And I think it's important that we sort of encourage clinical trial participation. Just to give you a sort of a perspective, there has been a lot of advances in pediatric cancers because 50 to 60% of pediatric patients enroll on trials. But the adult cancer patient participation in clinical trials in the US is only 6%. And there's a feeling that even if we doubled the participation from 6 to 12%, we could make significant more advances in managing many of the diseases, including small cell lung cancer. A couple of last points. This is a difficult topic, but I wanted to mention there is a tremendous aversion among patients about hospice. And I want to say that in some patients there does come a time where active treatment is not going to be very beneficial to the patient, but that patient still needs care, still needs medical attention, and that medical attention can be given to the patients at the patient's home instead of the patient coming back and forth to the doctor's office. And hospice is much more about ensuring that whatever lifespan the patient has, that is spent with as little symptoms as possible. But hospice, unfortunately, in the community has sort of been equated to, oh, the doctor has given up, and basically the doctor is sending the patient to hospice to die. And that has happened because of us, because of we doctors are actually not comfortable mentioning hospice until it is extremely late in a patient's disease course. And we therefore these patients are not in hospice for a very long period of time. And the impression created in the community is, oh, hospice means they're just being sent to die. Whereas hospice really is being able to ensure that the patient gets the care of palliative care that they need, so that their symptoms are as well controlled as possible. But beyond, initially it was only about hospice care, and that was instituted mainly in patients where it was felt that active cancer treatment was not going to be beneficial. But there is greater recognition that in cancer patients, and many times irrespective of the stage, there are a lot of symptoms from the cancer, symptoms from the treatment, symptoms from the emotional impact of the cancer on the patient. And I can tell you, as a medical oncologist, we are very good at managing the cancer, the treatments of the cancer, but sometimes we need help. We need experts to manage the pain, manage the shortness of breath, psychological symptoms like depression, support for family members. And I think that palliative care is becoming more and more important in the care of the patient. And many of my patients not only see me, but see palliative care. And I really think that it's critical upon us oncologists to ensure that the right information is provided about hospice care and palliative care to the patients, because many times when we bring up palliative care, some patients think, oh, no, I'm doing well. Why are you talking about palliative care? And it is really ensuring that we are addressing the patient comprehensively. I always get asked about nutrition and cancer. And what I tell patients is that nutrition probably does have a role in preventing cancer, But at the present time, we don't know that a particular diet or a particular food item helps in controlling the cancer that has already developed. And so my advice is that patients eat a balanced diet. And I'm very I consider it important to discuss this because in the middle of chemotherapy, radiation, even the contrast dye, sometimes you lose appetite, you feel nauseous. And then on top of that, if you institute too many nutrition restrictions, you may actually land up, losing weight, losing muscle mass, and that might be not so beneficial for the patient. So I really think nutrition is important, but I really don't think at the present time we have information that says that particular diet helps control a cancer that has already developed. Now, lack of information doesn't mean that there is no validity in that, but at the present time we don't have information, and therefore I would say we all know what a balanced diet is, and that's what we should sort of stick to. Exercise has a very relevant role in the management of lung cancer. All cancers, but I would say particularly lung cancer. And exercise doesn't mean you have to run a marathon every day or do 300-pound weight lifts, but maintaining activity level, keeping the muscles going as best as you can, even if it means pacing up and down in the room for 2-3 minutes, is relevant because it helps fatigue. It has been shown in some patients to reduce recurrence of cancers and does help other medical problems, including things such as constipation, abdominal bloating that can occur in some patients because of chemotherapy and other medications. So I know I've talked a lot. Most importantly, we are making progress in small cell lung cancer, but this progress is not as substantial, very candidly, as that has happened in non-small cell lung cancer. But I, as an oncologist, always want to have hope. And if I, as an oncologist, want to have hope to do my job, I have to believe that patients need hope a lot more, because this is not easy. But nonetheless, all of you do such a marvelous job dealing with this disease. And so I wanted to convey to you a story of a patient of mine who I have the privilege of taking care of for the last 3 years. This patient is now in her later 50s. She was diagnosed in her mid 50s. She had a cough that led to a workup, and she had this lung cancer, and then she had some REB metastases. And we started her on chemotherapy and immunotherapy. She had a wonderful response. And because she had such a wonderful response, even though she had extensive stage disease, the cancer had spread, but the cancer responded so well that we did do radiation to the chest disease. This is at the time of diagnosis. The cancer had shrunk quite a bit after getting chemotherapy and immunotherapy. But about 6 months after completing the radiation in around February of 2021, and this is in the middle of February of 2020, right before the pandemic, she developed brain metastases. She was found to have brain metastases on MRI scans that we were doing on a regular basis. So she got brain radiation. But ever since, she's been just receiving the immunotherapy maintenance immunotherapy. Now coming up to 3 years in January, it's already been 3 years since diagnosis. And this is her scan. I don't know whether this patient is cured. She had extensive stage small cell lung cancer, and in the past, we never believed we could cure extensive stage small cell lung cancer. But now I hardly see any cancer on her scans. She's doing well. She was a teacher. She continued to teach, but recently retired, and in my opinion is leading a full life. And I cannot tell you, as a lung cancer doctor who's been doing this for 22 years, what it means to have a small cell lung cancer patient who got chemotherapy, immunotherapy, radiation to the chest, radiation to the brain, and is now 3 years out from a diagnosis of lung cancer. And on her scans, I really don't see any distinct evidence of cancer. Though this story is limited to a minority of patients, but I can tell you that I'm very certain that with the clinical trials that we are doing, I'm certain that that proportion is going to increase, and we just have to keep pursuing these things. So thank you very much, and we'll be happy to take any questions. And I sincerely hope that at least some of your questions may have been answered by what I presented. So thank you.
Thank you very much, Dr. Gadgeel, for that very comprehensive report. It was really very thorough.
That was wonderful, and I love that story. So there is hope. Look, I was diagnosed in 2006. So here I am, and had, of course, the immunotherapy was not exist. This is amazing. Mm-hmm.
We do actually have a couple of questions in chat. One, and I might actually call on you, the person who asked this question. She says, what if you don't have PD-1 markers? She was just pulled off of Tecentriq after months of treatment, and then she had a recurrence in August, and they looked for biomarkers. Any suggestions? And if this person would like to jump in, feel free.
It was me who put the question in. Biomarkers are very new to me. They were just tested for, and I was taken off the Tecentriq, and I thought I was kind of like, it was implied that it was going to be my miracle worker, but I was taking it with no, success because I don't have PD-1 markers. So, it was kind of like a wasted thing that I was hanging my hat on. Recently, my oncologist did a blood biopsy, and she's waiting now for a report to see if the marker, a needed marker is there, but she has some drug in mind because I do have something. I really don't know. I'm sorry. I don't know the specifics about this. This was just mentioned a few days ago.
Just to be sure I got your case story right, you were started on chemotherapy and Tecentriq, and then you were maintained on, and does carboplatin etoposide ring a bell as far as chemotherapy?
Yes, that was what it was. Yes.
And when did you finish your chemotherapy?
December of 2021.
Okay, so you finished your chemotherapy in December of 2021, and in August of 2022,
I had a recurrence.
Started growing. Okay. So, I want to be careful in what I say, because I don't know I'm just sort of saying this, and, you need to talk to your oncologist. I'm not trying to give kind of disclaimer for any, but but every case is different. So let me say that in general, when cancer recurs, there is in small cell lung cancer, this cutoff of 6 months. So if the cancer grows 6 months after stopping chemotherapy, the first chemotherapy, which is carboplatin etoposide, the general standard treatment is to restart that chemotherapy. Because if it's the cancer grows within 6 months, then generally we don't. But if it grows after 6 months, and in your case, it looks like it was 8 months, that we resume the original chemotherapy. And what I have done is I have continued the immunotherapy. There's a bit of a debate between lung cancer doctors as to whether you should continue the Tecentriq, but I continue the Tecentriq and add back the carboplatin etoposide. Now, please.
She put me on Zepzelca. I'm taking that lurbinectedin.
The lurbinectedin. But that's fine if lurbinectedin was done. And did she continue the Tecentriq with the lurbinectedin?
No.
Okay. So again, I want to be very careful, but one of the simplest option, if the lurbinectedin has stopped working, is to try the carboplatin etoposide and Tecentriq again.
Okay. Well, that was I went to Sloan in New York for a second opinion, and they recommended that as well.
That's a consideration for sure. I want to go back to the PD-L1, and I want to make this clear. So the non-small cell lung cancer group is very familiar with the PD-L1. I want to tell you, we don't test for PD-L1 in small cell lung cancer, because the PD-L1 actually is not present on small cell, or present in probably less than 15% of small cell lung cancers. So we don't use PD-L1 like we use in non-small cell lung cancer. And irrespective of whether the cancer's PD-L1 is positive or negative, we use Tecentriq. The other thing is that I'm not sure exactly what is being assessed in the blood for you, but the blood test that we normally do, did the doctor say which blood test you had done?
No, not yet. Not with everything. I don't have.
Was that done already or not?
Yeah, it's reports are coming in, but she
Okay.
doesn't have all the information yet. So
Okay. Generally, again, I'm not sure exactly what blood tests. So the blood tests that we generally do, again, in non-small cell lung cancer, is these genomic tests to identify a particular sort of mutation that we can target with a drug. But in small cell lung cancer, there's generally never a single mutation. There are multiple mutations together. And so it is difficult to do a single drug based on a genomic test. But again, I don't know what blood work that is being done. I do want to say one thing very uncommonly, and I want to be sensitive. There may be some patients here but in small cell lung cancer, it is somewhat uncommon to have a never smoker. It is about 5-6%. Again, there are obviously, I'm sure there are examples in this group also. And if somebody has small cell lung cancer and is a never smoker, or I would even say has smoked, but smoked for maybe 10, 12 years and has not smoked for 30, 40 years and then has developed. But in those patients, I would do the genomic testing because there is a possibility that some of the markers we see in non-small cell lung cancer, we may see in small cell lung cancer in patients who are never smokers or have smoked very little. But usually we don't do the genomic testing either in the tissue or in the blood when it comes to small cell lung cancer. I'm not suggesting what your oncologist is doing is wrong, but generally we don't find it. And, I think you look amazing and I feel like, you should consider. And did you ask when you went and saw, when you went and saw the doctor at Memorial, whether you put, and maybe the distance is a bit far, but whether you were eligible for any trials or?
Yes, they put me in an exercise trial or something like that.
Okay.
It was kind of like
but not on a treatment trial.
Not on a treatment.
Okay.
No,
But
they made that recommendation to go back on the first one, which I tolerated very well. I'm having more trouble on the Zepzelca. It's reducing my platelets to nil. I've had transfusions and everything, and I may look good, but I don't feel good. And as a matter of fact, I passed out about 3 hours ago. So I stood up too quickly and just went right down. So I had chemo yesterday. So
the other thing I want to say is it is very important. There comes a point in patients where you have to give them a bit of a break. If you've been on chemotherapy for the last 3 months and your scans are looking good, there may be value in taking what we call it a therapeutic or a treatment holiday. It is possible that your body needs a tiny bit of a break, and then repeating a scan in about 6 to 7 weeks to say where you are may not be unreasonable. So that if we have to restart treatment, your body would be in a better shape to tolerate the treatment.
To go back to the original treatment. Yeah.
That's a great question. I was going to ask something similar about that PD-L1. I was wondering if it was always common since it is a standard level of treatment, but I'm glad you explained that. Yeah. Because I know non-small cell, usually they test for that biomarker, the PD-L1.
Yeah.
Can I ask a question?
Sure.
Please.
I was diagnosed in August of 2018. We canceled our first world cruise, or not world cruise, but ocean cruise, because my oncologist said, we're starting your chemo now. And thank God. But I had 4 sessions of etoposide and carboplatin, and I had 28 days of radiation with extensive small cell. And you're saying that's not common. So I asked him once in the beginning about immunotherapy, and all he said was no, he wasn't going to put me on immunotherapy. Now, I've been in remission for almost 4 years, knock-wood. I did find I had 4 tumors in vertebrae. So they did stereotactic radiation and my pain is greatly lessened. But my question is it too late? The little bit of spot in my liver can't be seen since the chemo. My main tumor went from over 8 centimeters to about 2. And like I say, I've been stable. Is there some point where I would still be a candidate for immunotherapy, because we know it's going to start to grow again?
Absolutely. So back in 2018, the immunotherapy was not approved. immunotherapy for small cell lung cancer got approved in 2019. So that's why they did not use it. But God forbid, if your cancer starts growing again, I would use the same chemotherapy, the carboplatin etoposide with the immunotherapy. So I wouldn't do necessarily immunotherapy by itself, but I would consider chemotherapy and immunotherapy. Having said that, there is a possibility in a patient like you, which is not common in small cell lung cancer. There is a possibility with the course you've had that it may start growing only in one area and everywhere else it might be controlled, in which case it would be perfectly reasonable to just do a local treatment, whether radiation or surgery, just to that area. And I would really rely on the chemotherapy, immunotherapy if it was much more of a widespread recurrence.
Thank you.
Two people, one person is from the UK, and she was wondering when she can expect to see these treatments in the UK, and she's like, how far behind are we? And then I also had another person from Poland who was pretty much asking a similar question about, are there any clinical trials in Poland? Where would people who do not live here in the US, where would they go to find out about clinical trials?
Poland, in Gdańsk, I hope I'm pronouncing the name of the city well. There is a wonderful, wonderful thoracic oncologist. He's the only Polish oncologist I know, so I apologize, but he is just an amazingly brilliant physician. As far as UK concerned, United Kingdom does a lot of clinical trials, and I really would, reach out to the major centers in, London, Manchester. There are a lot of wonderful clinical trial sites there. As far as drug approval, yes, drug approval overall, not always, but overall does occur faster in the US as compared to the European countries. But the time difference between Europe and US and Europe is reducing quite, substantially on many drugs. So I have to believe immunotherapy is either approved or going to be approved relatively quickly. The other drugs that I discussed, please note, they are still in development. So they are still in clinical trials. So they are also not available in the US. And the oncologist in Poland, his name is Dr. Gadgeel. So it is spelled DZIAD again, ZIUSZKO. Gadgeel is how we call him. Raphael is his first name. Just a brilliant guy. And I'm if you can reach out to him, I'm sure he can direct you as to where you can get the best trials in Poland.
Thank you. Vicky said that she's a never smoker. She says theory is caused by radiation for left breast cancer over 30 years ago. Would her treatments be handled differently from a smoker? And she's on her last round of cisplatin and etoposide and has had 3 weeks of radiation twice a day. She's stage 3B.
So a couple of things, yes. No, the treatment would be the same. But I think I would consider a couple of things. One is if you're a never smoker, it may be worthwhile to get your tumor under what is called as next generation sequencing, just to be sure that you don't have a gene alteration. And I wouldn't do anything specific if we did find a gene alteration right now, but it may be relevant, God forbid, if there was a recurrence. And the other thing I will say is that I know that you had radiation and that's what they believe, but it may be worthwhile, and probably your oncologist has already done it, and I don't want to add to any anxiety or stress, but it is important to get a proper family history in your case, just to be sure that there may not be a hereditary genetic syndrome that is running in the family. Just a thought. But it would be worthwhile to get a detailed family history to be sure that there may not be some sort of a gene alteration that you have inherited that has put you at this risk.
Wonderful. Thank you, Dr. Gadgeel. Thank you. And then the last question in chat is from Rayanne. She's asking, why does immunotherapy stop working after a period of 5+ months?
Yeah. So as I mentioned, very frankly, in majority of the patients, the adding immunotherapy does not work. You get the benefit that you get with chemotherapy. Then there are patients where the immunotherapy does provide benefit, but eventually cancer learns to overcome the effects of immunotherapy. Cancer is a kind of an evolving organism, and it sort of grows and learns and adapts to the immunotherapy. And then there is a proportion of patients where the immunotherapy is so effective in activating the immune system to fight the cancer that the cancer is just not able to adapt, and the cancer remains controlled for years together. I've given a long answer. Basically, we don't know what all are the factors that make the tumor resistant to the immunotherapy in the first place, or after there is a benefit from immunotherapy, how does the cancer adapt and the immunotherapy no longer works? I really believe that, what I briefly mentioned, where we are going to do the genomic analysis and identify the subsets of small cell lung cancer, that is going to give us some leads in understanding this better. And hopefully that will lead to better treatments.
Wonderful. Thank you so much. You shared so much, and your patients are very lucky to have you. So thank you very much.